Okay, I think we'll go ahead and get started. Thank you very much for joining us today for our fifth annual Frugal Innovations in Global Health Conference. My name is Allison Lofthouse. I'm the Assistant Dean for Global Health at the University of Illinois Chicago School of Public Health. We have this annual conference is co-sponsored by a number of the area institutions, and that includes Rush University, Loyola University, University of Illinois Chicago, as well as the India Development Service. Just going to say thank you to our partners and our co-sponsors of this event. Each year, we have the conference focus on a theme, and this year's theme is Artificial Intelligence and Frugal Innovations. We have an absolutely stellar lineup of speakers. We are so grateful for their participation, and I'm going to leave it up to our moderator, Mr. Jerome McDonald, to introduce them. Next slide, please. So frugal innovations, why do we care about them? Well, frugal innovations lower costs by using frugal technologies and changing where patients get care and who provides it. We know that folks around the globe have unequal access to care. According to the WHO, in 2021, over half of the world's population could not obtain essential services. We also know that there are rising healthcare costs. So there's great appeal for the development of newer technologies that are low cost and have an impressive return. Importantly, these frugal innovations have universal applicability, so they're not just limited to settings with low-income economies. And with every day that passes, the health and tech communities are learning how to integrate AI technologies to transform healthcare processes and improve decision-making and patient care. Next slide, please. The World Health Organization says focusing on artificial intelligence in healthcare is essential due to its ability to improve healthcare and tackle global health issues, including meeting the Sustainable Development Goals. Some ways AI is being used today is for outbreak prediction, health monitoring and wearable devices, research on non-communicable diseases, and this is just to name a few. Today, we hope to enhance understanding of AI's potential to transform healthcare and also to encourage that it is developed in a safe and ethical manner. Next slide, please. Okay, so please, just so you are aware, if you want to hide the subtitles, you can do that by hovering over the lower part of your screen, and there is an icon that will pop up that says hide subtitles. So no problem. If you want to turn those off, go ahead and turn those off. So you click on live transcript and then hide subtitle. Next one. We do encourage you to submit your questions to the presenters. We're going to have plenty of time for question and answer session. So please use the chat function that's within Zoom. Again, thank you very much to our inspiring speakers, to our moderator, our program planners, and all of you for joining us today. We're really excited about this fifth annual conference in global healthcare. Okay, next slide, please. All right, so without further ado, I'm going to go ahead and introduce our moderator. And Jerome McDonald spent almost 40 years with Chicago's public radio station, WBEZ. For 25 years, he hosted the radio program Worldview. He spoke with political leaders from UN Secretary Generals to Secretaries of State, but Worldview is best known for its focus on human rights and global well-being, talking with experts in global health and education, and featuring many social entrepreneurs. Jerome is currently on the board of Chicago Fair Trade. He volunteers with Friends of Illinois Nature Preserves, and he rides his bike a lot. So with that, I'm going to turn it over to you, Jerome. Thank you.
Thanks, Allison. It's a great day here in Chicago. I'll ride my bike right after the conference. But first, I'm really excited about being inspired and being a part of the conference once again, because I always get such a charge out of hearing about new ideas that can really help people around the world. I think we all do. And so it's always great to be here and have an inspiring morning. And I really like the topic this year with artificial intelligence and high tech. Got to admit, I'm a radio guy. I worked in kind of an ancient medium, and around my house, I'm married to an illustrator, and artificial intelligence is like a bad word to illustrators. It's something that is stealing jobs from illustrators. It is making kind of crappy computer art all over the world. And there's kind of like a negative vibe in my house about this. But, it's interesting. The thing that turned me around on artificial intelligence was really global health. And when I started hearing about the potential and hearing about how it's being applied to tuberculosis and how it's being applied to the drug regimens and how it's being used to fight uh, disease, the resistant tuberculosis, I got excited. I thought, oh, it opened my mind, and I said, oh, this is going to be fantastic. This is going to be able to save lives. This is going to be able to do things that I can't quite even conceive of. And I am so happy to be in that space this morning and wallow in that goodness of technology and see where things are going and talk with people who are on the front lines of all this. So I think we've got an exciting day planned. And we'll start today, with a great keynote, I think. Nina Schwalbe is here. And Nina Schwalbe is currently the CEO and founder at Spark Street Advisors, and it consults on health and global development issues. And she's a senior scholar at the O'Neill Institute at Georgetown University as well. But the rest of her resume is completely awesome and kind of reveals her as one of the great global health people that we've produced in this country. She has been director of public health programs at the Open Society Institute Soros Foundation. She was on the founding board of the Stop TB Partnership, was director of policy at the Global Alliance for TB Drug Development. And Nina was at Gavi, the Vaccine Alliance, for 7 years, much of it as the chair of the Gavi Evaluation Advisory Committee. She was UNICEF's principal advisor and acting chief of health. And she was the first COVID-19 vaccine access and delivery initiative director at USAID, which is a lot, which is kind of a miraculous resume. And it would be so great to hear her perspectives on this. And it's just great to have Nina Schwalbe with us. Nice to talk with you, Nina. Nice to see you.
Great. Thank you, Jerome. I'm very happy to be here. Thank you for inviting me to join you all today. So I'm going to talk a little bit about AI in global health and what we mean by it. Next slide, please. As an academic, I always like to thank my co-researchers, Brian Wall and Susan Lechtomaki. They've both done most of the work that we've done together on AI in global health. Brian is at Yale and Susanna is based in Lisbon. So I thought about having their picture on every slide, but we'll leave it here for now. So next slide, please. The first thing I want to talk about is what we mean by AI. There are lots of different types of AI, and there's what we call sort of general AI, which is HAL from 2001 Space Odyssey, or narrow AI, which is really what most of us are using more and more to answer day-to-day questions and to help inform our lives. And I put up on this slide a number of examples. Natural language processing, tools like ChatGPT or Google Translate. We have image and signal processing, which is when we put our finger on our phones or our face to open our phones, or facial recognition at the passport office. We have machine learning. We have automated planning and scheduling, so that can help us schedule a doctor's appointment. So there's really a wide range of things that how AI is being used in our everyday life. And this is what we mean when we talk about AI. Next slide, please. In 2019, we were asked by one of our collaborative organizations to talk and look a little bit at how AI is being used or was being used in low and middle income countries. And their specific question was, there is a shortage of staff, and that's a big problem. And what kind of AI interventions could be used both to increase quality of care, but also to help with a general and overall staff shortage? So within this paper, we did a bunch of things. We looked at what are interventions that are being used already, what's been deployed out there in low and middle income countries. Is there sufficient evidence that these are actually working? And what kind of research is needed further? Because as researchers, we often ask that question, what kind of research is needed further to support further implementation and a research agenda for low and middle income countries? Next slide, please. So we identified a ton of tools out there, many different types of tools being used, from X-ray diagnosis for tuberculosis, and I think we'll hear more about that, to algorithms that can help identify risk of dengue fever severity in particular areas, looking at geospatial data to look at transmission patterns for Zika virus, and even algorithms to look at predicting how much time health workers spend in a particular geography when they're going out doing their day-to-day work. So we saw that it was being used in a variety of areas, diagnosis, mostly morbidity and mortality assessment, outbreak prediction and surveillance, and policy and planning. And that was great to see so many pilots out there. Next slide, please. And yet there were some definitely missing things within the research that we identified. While we did interview a range of really cool tools and cool, very exciting interventions, we found that the ways that we traditionally assess effectiveness and quality were not being applied to these interventions. So they were described within their own sort of bubble about the particular intervention, not if it was more cost effective than the current intervention, less research, what we call implementation research, about how it fit into the health system overall, how it was being accepted by the people that had to use it, what were the standards that were being applied. Some of these tools were being deployed immediately by health systems without going through the regular kind of quality assurance processes that we rely on in order to maintain quality in the field. Next slide, please. So what was missing? Human-centered design. We talk a lot about working with the communities and having new technologies derived from the communities, but we found that a lot of these tools or interventions, I'm going to call them both throughout this talk, were being developed like a great idea from somebody, a researcher, a scientist, whether it was coming from a high-income country or a low or a middle-income country, but it was being developed by the researchers rather than out of the needs of the people or the problems that they were trying to solve. So it was like, great tool, let's find a problem for it. That the data sets were problematic, particularly for underrepresented populations. They were still more or less being developed. And this, again, this was 2019 when we put this out. They were still being developed using data sets mostly from high-income countries. As I mentioned, there was no system to think about how effective they were. We use a lot of different tools in health policy. Health technology assessment is one that's used in UK to make sure things are better than the standard of care, that they're doing more good than harm, et cetera. None of those kind of classic tools were being applied, and that the regulatory and ethical standards really weren't up to speed vis-a-vis the types of standards that we have for other clinical interventions. And in particular, one kind of pervasive problem in this field is that for most medical interventions, you're evaluating them at a point in time, and these were continuing to evolve. So even where they were being evaluated, by nature of these interventions being iterative with improvements in AI, they're evaluated at a point of time, and then their use is continued without necessarily a strong evaluation point. So a lot of good work being done and a strong place to go. So next slide, please. We developed, as a result of this research, a framework to help people think about the iterative nature and how thinking, as you do when you're developing a drug or a vaccine, thinking about design principles, thinking about human-centered design, thinking about ethical standards and quality of care, cost effectiveness, need to be thought of from the start through the assessment and then development. So this is not, for those of you that do product development, this is not a new framework, but we wanted to iterate that it was particularly important as well with AI-driven interventions. And you'll see on this slide, equitable access to representative data sets, many of the things that many of you know, but that weren't being applied to these types of tools. Next slide, please. We also noticed that many of you who work in this field are aware of the so-called digital principles. These were first adopted in 2014 and have a lot of what we just mentioned. You see words like user-centered design, thinking about the structures and needs that exist in the country while you're deploying the terms, really working these through with stakeholders, basing the interventions on quality information, privacy and security. So these are not new words, but really not being applied in practice, despite widespread adoption by both the development community and the tech community. Next slide, please. So let's fast forward to 2025. So we wrote this paper in 2019. It was accepted by the Lancet in early 2020, and they were so excited about it that they were going to publish it in May 2020 at the World Health Assembly. And then other things took the minds of the public health community, particularly COVID-19 and the pandemic. So this kind of research and our work, it got a little buried and was sort of put on hold, at least from our perspective as researchers. So fast forward to 2025. And it's a different world that we live in. So first of all, the global development world has shifted unfathomably, and we'll talk a little bit about that later, with really the pullout of the US government, which provides about 30% of all health aid globally from the international development arena. So with the cancellation of USAID, PEPFAR, and other programs that supported global public health, on one side, really dismantling a lot of services, both in our country and then also around the world. And then this massive explosion of the use of AI in all aspects of our life. And those 6 years ago when we did that review, not surprising, but in particular, tools like ChatGPT, which everybody's using now. So it's a different world geopolitically, and it's a very different world technologically. Next slide, please. Also in the field of global health at the same time, during that 6-year period, and during that 6-year period, there's been a change in how we think about global health. And that came across, that was a movement that had started before COVID, but during COVID, particularly with the massive vaccine inequities and the fact that high-income countries had access to medical products and vaccines and low-income countries did not, there's been a big move to think about decolonization of global public health. And so we took a look at this. We were originally intending just to update our review and look at what are the new tools out there 5 years later or 6 years later. But we decided instead to look more at this issue of how AI had affected research and research methods, and how it could potentially present opportunities to democratize how we do and think about research and contribute to this decolonization effort. So we took upon the research question, which is listed here: how can AI strengthen research capacity at LMICs and contribute to the movement to decolonize global health? Next slide, please. We undertook a systematic review and to look at current evidence on using AI for strengthening research capacities, particularly around research capacity, and then a review of reviews to look at the literature on decolonization. We didn't find a ton of papers, but we found some good ones. And we actually identified through this research several ways AI can be used to strengthen research. Next slide, please. There were a lot of positive ways in the last, particularly in the last 2 years, a lot of the papers were from the last 2 years, that researchers have been supplementing their work, including in LMICs, with AI-driven interventions. Data analysis and research productivity using AI to clean data, to look at patterns, to do predictive modeling. Helping researchers synthesize literature, large volumes of literature or qualitative reviews. I have to admit that in my own research, I use a lot of ChatGPT and Claude to help me when I'm coding. When I get mistakes in my code, I put it back into ChatGPT and Claude, and they help me fix my coding mistakes as a dyslexic, that's very helpful because I often get commas and periods wrong. So, or just helping me think about how to do analysis differently. So that's another way, or helping interpret statistical tests, or helping think through using that as an iterative tool around what kind of statistical tests one should use. And then basic things like writing support. One of the classic reviewer comments that we've even gotten when we submit research is, it would be helpful if this was reviewed by a native English speaker, which always makes me laugh because I am a native English speaker. But even the use of Grammarly or a tool as simple as that can help. What we also found is that it doesn't obviate the need for the skills that you need to have already. You need to know what questions to ask, what statistical tools to use. Human oversight is crucial, and you still need to know how to be a researcher and ask the right research questions. There are also some problems with the tool in that if you rely on it overly, it can plagiarize, it can hallucinate, which basically means it makes stuff up. And it's dependent on all the same risks that we talked about before: data quality, data input, garbage in, garbage out. Next slide, please. Checking my time. So our key takeaways from that were that that deployment in different contexts remains uneven, and much of the AI design and use is still concentrated in high-income countries, but they're promising practices. People are aware of the risks. There are also pervasive concerns about data quality, transparency, and accountability. And we need to really think more about how to evaluate the effectiveness of the use of these tools, because it's being done in a very ad hoc way, and where can we improve on that? And I'm going to end this talk, or the last part of my talk is going to talk about the data roadblocks, because this is really, I think, for us and for our team, the most critical and worrisome part of the world moving forward. And before that, just this box in yellow, which is absolutely convinced, and all the data and evidence show that this is not instead of researchers. This is a supplemental tool. A couple of people called it like a very smart research assistant to help kind of limit your time as a researcher, as a senior researcher, doing things that can basically be automated. So the next slide, please. So the common roadblocks are data. And these are issues that we have not yet fixed. And I was at a conference at Yale University last week, and these came up over and over again: data access, data sharing, data privacy, data security, data representativeness. Next slide, please. We did a paper a couple of years ago I can't remember when it was, maybe 3 or 4 years ago. It was during COVID. People were talking about a lot about data in public health, and we just wanted to categorize what we mean by data in public health. There's individual data, genomic data, omics, there's electronic medical records, there's wellness data. People are wearing Fitbits. I don't have one. There's health systems data, there's census data, there's population-based data. So there's a lot of different data. And we wanted to sort of categorize it so that people, when they were talking about data, just didn't talk generically, but could talk specifically about data, where it's held, and what are some of the potential pitfalls around those particular data sets. Next slide, please. So data security and privacy. In order for us to democratize AI and make sure that you have training sets for data, that there are data training sets to train your model on, you need data, you need big data. But there are big questions still around who owns your data. Is your data private? Who has the right to share your data? In our own healthcare system, yesterday there was a notice from my provider in New York City that said that they had now collaborated with Amazon, and they're going to use an Amazon handprint when I check in at my hospital, which I must say doesn't make me super comfortable. So who owns my data? When did I give up my data? I was at this conference at Yale, and the guy said, one of the speakers said, "How many of you have read your Netflix agreement?" Well, that's what most of us are being asked to give away, or when we do data agreements, most of us just sort of click through that screen. The next slide, please, is around this idea of data sharing, access, and benefit sharing. I've done a lot of work on this in the context of pandemic preparedness and response, and particularly thinking about pathogen access and benefit sharing, which is a big part of something that I work on called the Pandemic Treaty. And the idea here is that South Africa shares its Omicron data, sequencing data with us after COVID-19. And pharmaceutical companies make products out of that, and those data are not given back, and those products are not given back to South Africa after they've shared their data. And in fact, even more worrisome, we close our borders after that kind of, after they report an outbreak and share their data with us. So there's lots of ways. There was a very book, if you haven't read it, The Immortal Life of Henrietta Lacks, talks about how a lot of our scientific research in the US is based on a patient at Johns Hopkins who never had access, or nor did her family, to any of the research that was generated. So another big issue that there is no answer to, and we haven't answered to, as we have not answered as we go forward and continue to innovate, develop. Next slide, please. Data representativeness, who gets counted, who are we counting in our large data sets, who's missing, who's not part of our data collection, and why. Clinical trials, there was a lot of discussion. I think the research community has known this for a while, but it came out during COVID that we generally don't test new medicines, for example, on pregnant women. And so pregnant women are often not represented in clinical trial data, and thus there's no efficacy data for them. It's also clear on people of color, on other minorities. So we have a bad history of data representativeness in clinical trials and studies, et cetera. That's only going to get worse, certainly in the US and in programs that we fund overseas, with a new executive order that gets rid of any specific mention of diversity, equity, or inclusion. And this is a problem too with AI, in that most of our large scale data sets are based on data collected, or many of them that we're using for health are based on data collected in high income countries. Next slide, please. So I didn't come up with this particular term on the left, frugal or feudal innovation. My team did, and we had an interesting discussion around it, that if we don't solve the data issue and think about data representativeness, privacy and security, sharing and access benefits, we risk that frugal innovations become feudal innovations, because they will perpetuate inequities that already exist in the healthcare system. And we need to really double down on both the digital principles of how we develop tools, but also making sure that as we start to think about being more inclusive, and researchers start to think about being more inclusive, that it's really multi-directional. And on this slide I have, so that low and middle income countries don't become hotspots and then not get affordable or usable products, but also individuals benefit from their data being used and shared. So I'll turn to my last slide, please, and come back to this algorithm that we've put forward, or schemata or framework on responsible development, which is user-driven research agenda. So we shouldn't be coming with tools and applying them to populations. We should listen to people for what they need. Incorporating human-centered design and equitable access to data sets in research and development, thinking through a standard way of assessing these in the way that we think about assessing healthcare innovations, and not treating them as other and unregulated. And then also thinking about what it means to deploy them. What are the standards that we set, both ethical and regulatory, for thinking about how we use these new tools. And all right, there's another discussion too about how we think about statistical validity in assessment of these tools, but I'm going to save that for another exciting talk. And thank you very much for this. Next and last slide is just to say thank you all.
Thank you, Nina. That was very thought-provoking and interesting. Yeah, the whole decolonization of public health with AI and how it can help or hurt is a kind of a mind-blowing concept. And I wanted to ask a question about if it's all about data, how do you decolonize the data? It's who's in charge of the data that is inputted here? Because it seems like a lot of it might be Fitbit might have more information about some healthcare aspect than the government of Botswana, or are there people like Apple or who have more data inputs on public health than governments, and does that make equitable decolonization it just seems to multiply rather than get worse rather than get better.
Yeah, I think a lot of it is that individuals really aren't aware of the rights that they're signing away when they sign it. It's complicated. It's complicated, Jerome, because it also depends on the data set and the type of data. So it depends on the type of data that we're talking about and who owns those types of data and how they're being used. I think there's a lot right now happening of outsourcing of data to the private sector. And I think that was the example I gave in our hospital system here is one of those, outsourcing it to Amazon to collect our data prints. What are the data agreements? What is the data privacy issues? There's been a history in global public health researchers of researchers going in and kind of doing studies and then bringing those studies out and publishing those studies. So it's a complicated question. And I think it depends on the type of data that you're talking about. But there could be agreements that if if somebody has a Fitbit program and people are buying them in Botswana, that the Botswana government also has rights to those data.
Is there a good example about decolonization of public health with AI? Is there some good example out there?
I think that the WHO flu database is a good example. So WHO collects flu data for seasonal flu from everywhere in the world. This is less on the AI, but more on the good practice on data sharing. They collect flu data from every country where they have surveillance sites. And then based on that, they recommend the optimal flu vaccine. And then that composition of that vaccine and even seeds for those development of those vaccines are available to any country that's input or given of their own data, and actually more broadly.
All right. And then, like, how do you get places to adhere to the digital principles? Is that it sounds like in that case people are aware and doing it, but how do people enforce that kind of thing?
There's a group called Transform Health, which is an international NGO, which is trying to use some of the kind of tools like Amnesty International to say, Google, Facebook, you signed up to these digital principles, your name is on them, you endorse them, so let's see some action. I think there's a lot of action that's being done by civil society and by shareholders and some of the groups that care about transparency and technology to kind of hold these companies accountable for the commitments that they've made.
There's a question in the chat from Danny Nyatuka, and he really wants more information on accessing the publications you were talking about. And he is curious about the decolonization data and would like more information.
Great. The first two papers I can put in the chat. They're both public access. We only publish public access, and the third is a work in progress. So it's you were all the first to see it, and we hope it'll be coming out shortly, and we're happy to share it when it's published.
And another question is, how can we improve data collection to improve representativeness in global health? Does human-centered design bridge some of this gap?
Human-centered design is important. It's a really good question. Thank you for it. I think I would say that the representative data samples is really on the researchers to make sure that that's part of their research design and to think about it from the get-go. And that's this idea of the human-centered design is who's the population, the end user that's going to use it, and the appropriate research questions and data should feed into that end user. So it is linked to that indeed. And this idea of putting forward, it's just remarkable how many researchers don't think about the representative of data before they move forward, or they think it'll be done afterwards, or it can just be an afterthought, even when in theory these interventions are being designed for people who might not be part of the data set.
We're about out of time, but I did want to ask you a question about the time we're living in, and you know, your entire resume and global public health and public health in general is not being supported by the U.S. the way it used to, and it's almost a revolutionary kind of moment in public health, and not in a good way. It seems like everything on your resume is under attack. How do you react to what's going on now? What do you think's going on?
I think global health as we knew it is gone. It's really the slash to USAID was devastating for programs and people around the world. The slash to the President's Emergency Program on HIV/AIDS has left millions of people without treatment, millions of people without access to tuberculosis treatment, health workers out of work. And that's not to say that I think there was always a discussion about the decolonization and moving more responsibility to countries, which remains the case. But I think doing it in a day was really was more than irresponsible. It was causing thousands and thousands, if not millions, of needless deaths. The field has entirely changed. In addition to the cutting of aid, the U.S. is on any existing remaining grants, they're imposing conditions on diversity. You can't talk about diversity, equity, and inclusion. You can't talk about any more than 2 genders. For a lot of the work that we do with on diseases of poverty and diseases that affect the most marginalized, those are just no-goes for inclusive research. So it's really remarkable to see in the course of just a few weeks a whole field get crushed. There's also some other signs that aren't very helpful. The UK has cut its development funding with the increased pressure on funding Ukraine and other priorities for Europe, as well as other inwardly looking, governments taking some cues from ours. A number of governments have cut their aid, overseas development assistance as well. So it's a whole new world.
Well, we'll have a chance to talk a little more at the end of the panels and the wrap up at the end. But thanks a lot for joining us, Nina Schwalbe, and lending your expertise and having that thought-provoking keynote. Thanks very much. We're going to move along now and talk with our next presenter, Dr. Subhash Narayanan, and he has developed something called SASCAN, and it's an oral scanner. It's an oral cancer scan, and it was actually awarded the most innovative product of the year at the BW Emerging Business Awards Summit that was held in New Delhi last month. And it's a product that looks like it has an opportunity to save some lives, and we're delighted to hear about it. Thanks for joining us, Subhash.
So, hi everyone. Good morning. Oral scan. It's an affordable and real-time solution for early screening and early detection of oral cavity cancers at the community level. The most important part is that the device can also function as a biopsy guidance tool so that false negatives can be avoided and the pathology can be made much more accurate than what is possible right now. So this kind of biopsy guidance is very useful in a resource-limited settings where people are coming for screening and early detection. So our company was founded in 2015 with a vision to develop affordable healthcare devices using biophotonics and allied technologies for creating a social impact in the society. And our company is ISO 13485 certified, and oral scan is our flagship product. Our company is incubated at the Technology Business Incubator for Medical Devices at Sridhara Institute, which is under the Government of India in Trivandrum. Next slide, please. Oral cancer is a lifestyle disease caused primarily due to the consumption of tobacco products and cigarettes and smoking, and alcohol and genetics also has a great impact in creating oral cancer across the globe. And sexually transmitted diseases also are instrumental in creating or causing this oral cancer in many parts of the Western world. In India, the primary reason for oral cancer is the excessive use of pan and gutka, which are tobacco products. And globally, if you look at the global incidence for oral cancer, according to the GloboScan survey, 389,000 new cases are detected in 2022, and India accounts for 1/5 of the global burden, which is more than 70,000 cases. 75,000 cases each year. These are new cases reported, but the main problem is that the mortality rate or death rates due to oral cancer is more than 50% even in developed countries. That's a global death rates are around 188,000 deaths are happening due to oral cancer. The basic reason for this is that the disease is getting detected during the late stages of its development, and this leads to the low survival rates happening across the globe. The conventional method of oral examination is with white light. It's a subjective procedure, and it's not very reliable because even experienced clinicians find it challenging to locate the grade of cancer or to locate a site for biopsy by white light examination. So even devices like Wellscope, Identify, and Oral ID are available in Western world, but these are not commonly used in India because of the high cost and the lack of accuracy. So if there are devices that can detect oral cancer during its early stages, the mortality or death rates due to oral cancer can be brought down to realistic levels of less than 20%. Next slide, please. Oral scan is an intraoral multimodal imaging device which uses a proprietary software and a machine learning algorithm for real-time assessment of tissue status. When light is falling on the tissue, most of it gets reflected from the surface, but a small portion of it goes inside, and that light goes inside is multiply scattered and absorbed by the biochemical constant in the tissue, and some of it is emitted as fluorescence in the long wavelength region, while most of it gets diffusely reflected. And this diffusely reflected light will carry information about the tissue absorbers that absorb the light. So this device, which is we have built, is based on tissue fluorescence and the diffuse reflectance of oral mucosa. Next slide, please. The heme cycle is disturbed in cancer cells because the heme production is low due to an enzyme called ferrochelatase, which is low in the cancer cells, and this leads to an accumulation of protoporphyrin IX molecule in the cancer cells. The heme cycle actually is the synthesis of heme in all mammalian cells. The heme is synthesized in 8 different steps in the cytosol and the mitochondria. And when there's a buildup of protoporphyrin IX in the cancer cells, if you use a light of suitable wavelength that absorbs that PP9, that is around in the solid band, there is an strong absorption 405. And if you use a wavelength 405 matching with the absorption of that band, we can have emission in the longer wavelength light. And this emission can be used to sense changes in the cancer development in the tissue. In addition to that, when the heme productions are less, the oxyhemoglobin levels are low in the cancer cells. So if we have, when you look at the absorption bands of oxy and deoxyhemoglobin, you can see a great anomaly in the absorption cross-section around 610 nanometer, where the deoxy is having a higher absorption as compared to the oxyhemoglobin. And oxyhemoglobin has two specific bands at 545 and 575 nanometer. So if you can use wavelength of light at 545 and 610 and monitor the diffusely reflected light, we will be able to sense changes in the changes due to the oxyhemoglobin absorption in the cancer cells. In our oral scan device, we use both 405, 545, and 610 nanometer to look at the cancer development in the tissues. Next slide, please. We started working on oral cavity cancers way back in 2005 onwards. And first we studied collaborating with the Regional Cancer Center, the diffuse reflectance spectra of surgically excised oral tissues. And we found that there's a correlation between the reflectance ratio at 540 and 575 oxygenated hemoglobin bands with respect to the development of cancer in the tissues. This work was published in the Journal of Biomedical Optics, and we use white light for excitation of the tissue, and we were using a very normal spectrometer to monitor the diffusely reflected light using a point monitoring probe. Later, we used added a 405 nanometer laser to look at the fluorescence of the tissue, and we found that the specific peaks at 635 and 710 nanometer show increased fluorescence with respect to the development of cancer. And we built multiple systems combining these two techniques, and we have published lots of paper like in journals of biomedical optics, BMJ Open, and Journal of Biophotonics. If you look at the changes in the diffusely reflected light, you can see that there's at the specific peaks of 540 and 575 nanometer, there's a lot of change in intensity when the tissue becomes malignant. Next slide, please. Going forward, we developed an imaging device using an electron multiplying CCD camera, coupling with it with a liquid tunable filter, and using white light, we captured wide field images of the tissue from the oral cavity and looked at the this being a monochrome camera, you can see the images captured are monochrome, and if you map the pseudo color changes in the ratio, you can see that wherever there's a cancer, the intensity of the ratio goes up. So this intensity change in the diffuse reflectance ratio, we found that could be a good indicator for determining the stage of the cancer. So we got very good sensitivity and specificity for discrimination between pre-malignant versus normal tissues. We got 95% sensitivity and 92% specificity in this clinical study, which was done in the regional cancer center. So we could determine even leukoplakia on the lateral border of the tongue with very good sensitivity using this technique. This was found to be a very useful technique, but the problem with this was that it uses a bulky equipment. It's very costly, and so there was a need to develop affordable devices that can be used in the community settings. Next slide, please. So this is with that in mind, we developed this intraoral camera, which consists of a monochrome 5 megapixel camera, and it captures images at 3 different wavelengths. One is the violet, that is to look at the tissue fluorescence, and green and red LEDs to map changes in the oxyhemoglobin absorption and the deoxy changes. And we developed a proprietary software that can be installed in a Windows system, and which will control the camera operations as well as the image processing. And we used a cloud-based machine learning algorithm to provide users with real-time feedback. Next slide, please. You can see the working of the camera here. With one click, you can the LEDs are switched on sequentially, and the image capture happens in less than 2 seconds. Next slide, please. As I told, that we have a proprietary software that facilitates the patient data entry, and this the software can be integrated with the hospital management data system, so that the data from the hospital management system can be pulled, and the patient can be enrolled much faster than what is possible otherwise. And the important thing is that the device needs to be calibrated to the dark room conditions in which the measurement has to be made, because we need an intensity of around 5 lux to make the measurements reliable. And first of all, when the probe is switched off, the violet light comes on, and we can visualize the outer fluorescence with the naked eye in monochrome or in pseudo color. And before we capture the image, once you locate the abnormal area, we focus on that area and select the anatomical site, and then the images can be captured. And the capturing time is very fast, and all the LEDs are fired sequentially, and the images are captured in less than 2 seconds. And once the capture is done, we can visualize the ratio images in black and white and pseudo color map. And to analyze the data, we have to mark the region of interest, and region of interest has to be marked at least in one abnormal lesion and a normal lesion. And the program will locate automatically the most malignant site, and the tissue feedback is given based on the machine learning algorithm, which is a cloud-based machine learning algorithm. And you can see that the tissues is categorized as healthy, potentially malignant, or malignant based on the slider position in the color bar. And biopsy is recommended based on the percentage change in the value of the healthy tissue with the abnormal tissue. And reports can be generated for sharing with the patients. And in these reports, a visual photograph as well as the results of the histopathology can be uploaded. And the data gets pushed to the cloud, and there's an algorithm will get refined over a period of time. When more data sets come into the cloud, the algorithm and the feedback to the user will be much improved, and you can have much more accurate screening using this technique. Next slide, please. This is a typical kind of algorithm. This is that in which the green dots show represent the healthy tissues and data from the healthy tissues, and higher values of ratio 16/540 ratio will represent higher grades of malignancy. And we observed that a sensitivity of 97% and a specificity of 92% was obtained for discrimination between normal tissue and oral potentially malignant lesions in a multicenter trial conducted across the country. And these results are published in the Journal of Biomedical Optics in 2021. Next slide, please. Can you switch on the video, please? This is a video on the working of the oral scan device. You can see how the device the audio. Can you switch on the audio, please?
Oral scan probe consists of circular arrangement of 3 sets of LED lights with a monochrome camera at the center. There are certain infection control measures to be followed, like the probe has to be covered with a cling film. While wrapping the front portion of the probe, it has to be wrinkle-free. The device is calibrated to the ambient darkroom condition. The device is supplied with a tissue phantom with the same properties as the human tissue. In the software, there is provision for calibration. Click the icon and the calibration window will open. Seat the device on the tissue phantom and click the calibrate icon. Each LED lights are being calibrated to the present room condition, and it will take some time. The patient details have to be entered. The areas marked mandatory has to be filled. Click on the View Problem area and mark the area to be scanned. The patient can be given a mouthwash, and the area to be scanned is wiped with cotton to remove saliva and other debris. The oral cavity is scanned with violet light, and the result can be viewed on the screen. The area with abnormality is identified and the device is focused. There is a button on the handle to capture. There is a capture icon on the screen. The image can be viewed with different light settings, and you can see the black and white image also.
The black and white and color images are viewed. The ROI is marked, then the analysis button is clicked. Then the result will appear. If the indicator is in the green area, it is normal, yellow is suspicious lesion, and red is suggestive of a cancerous lesion. The images scan can be viewed by clicking here. We can view the images taken earlier and can upload the clinical photograph, histopathology, and download the report from this page. Click on the clinical photograph button, then the photograph can be uploaded. Histology report can be uploaded from the drop-down menu here.
Due to lack of time, can we
Continued.
go to the next slide, please?
Download the final report by clicking.
Yeah, the uniqueness of the device. This is the first time in the world that an intraoral multispectral camera has been developed for and avoiding the use of expensive tunable filters and liquid crystal displays. And it follows a human-centric design philosophy where probe angulation, switch position, handle size has been arrived at in consultation with the users. And our software also was designed in such a way that the users find it extremely easy to operate, so that even health workers can learn the software and use it in remote settings on their own. It runs on a Windows system, which is very commonly found anywhere, so that any computer with a Windows system can be used to install the software. And it uses a cloud-based algorithm for user feedback. It uses minimal or zero consumables, and the results are shown immediately to the patient, and feedback is possible for later follow-up and other things in an immediate manner. Can we go to the next slide, please? When you compare the device with the existing device in the market, like Wellscope Identify and Oral ID, which are subjective, our device is objective, as it captures the images and analyzes the data with a cloud-based algorithm, and the cost-effective solution, because the cost is much lower than what is there for the Wellscope, which is subjective device. And the most important part is that the accuracy of the device is also much higher than what is possible with Wellscope, which just relies on the loss of fluorescence in the tissue to see whether the tissue is cancerous or not. It's all a subjective method. And can you go to the next slide, please? The most important aspects of the device are its affordability, accessibility, and accuracy. Our device is priced around $6,000 to $9,000. And it has no consumable cost or recurring consumable cost. And we have a model, monthly rental, as well as pay-per-use models are available for people with low resources. They can buy that and use the device on a very minimal cost. And most importantly, the non-invasive screening with real-time feedback is the most important thing, where the users find it very useful for giving the patient the feedback instantaneously. And this product is CE certified and is approved by the CDSO, and biopsy guidance wants to improve the pathology. And our technology is patented and has been scalable. It's scalable and it has been adapted for cervical cancer screening. And the product is undergoing clinical validation in various hospitals across the country. Next slide, please. And the device has been used extensively in screening camps across India, in community level screening programs, collaborating with the cancer hospitals, dental hospitals, National Health Mission, and state health departments are using the device, and NGOs and the Indian Dental Association. We have been collaborating and carrying studies, collaborating with the corporates and using the CSR funds in both urban and rural settings. We have screened a large high-risk population, example, the tuberculosis in certain pockets where the users are, prevalence is very high. And and this device is extremely useful for follow-up of patients during treatment or reviews. The usefulness of the device for early detection and screening and early detection of malignant lesions is very significant, and it also reduces the time from diagnosis treatment by early detection. We can have immediate treatment possibility. The data can be shared, the results can be shared with the hospitals for follow-up and treatment. And most importantly, that device can create a social and economic impact, because early detection can save a lot of cost of treatment and the families affected can also be much lower. The mortality rates can be brought down due to early detection. Next slide, please. These are some of the user feedbacks about the device. In the cancer rehab therapist, Dr. Kamaljit sir feels the real-time feedback provided by the device is very useful for awareness creation and biopsy guidance. And this Anand Goswami of the Medical Health Office in Panvel Municipal Corporation has used the devices in the urban primary health centers and the corporation. And he feels that the patients appreciate the instant results, which enable timely interventions and enhance the quality of patient care. R. Jayagashan from the Community Oncology Division feels that there's a good correlation between the clinically sufficient lesion and findings of the oral scan. Next slide, please. The benefits for the patient is through early detection and better prognosis. It's a non-invasive and painless and quick screening, and it reduces the cost of treatment and minimizes functional deficits, which are otherwise they are due to the late stage of detection. For healthcare providers, the most important benefit is the integration with the hospital management system and enhanced workflow with cloud support and increased screening accuracy and the ability to share the screening reports with the clinicians and hospitals for follow-up. For the health system, the cost-effective solution for mass screening programs, and it reduces the burden on tertiary care facilities and lowers the mortality rates due to oral cavity cancer. Next slide, please. In conclusion, I would like to say that oral cancer is a frugal, innovative solution that bridges the gap in oral cancer screening and diagnosis, especially in lower resource settings. It can transform the healthcare accessibility and outcomes through affordable technologies, and the social impact created through such devices in collaboration with the Government Health Department, Indian Dental Association, National Health Mission, and the NGOs can create a long way in implementing such screening programs across the country and reducing the death rate due to cancer. Next slide, please. We have been, since 2020, we have been implementing the device for early detection of the disease across the country. And so far, we have touched the lives of more than 12,000 people, and more than 1,200 cases of cancer have been detected using the device. And our motto is to save lives through early detection of cancer. And thank you for the patience. Thank you.
Thanks for that, Subhash. We're running a little pinch late on time, but I wanted to ask one question about how you see the rollout of this device and who is going to buy it and who's going to use it. It's because it kind of looks like an almost field device, but it's not quite a field device. Is it something for centers, or how does that work?
At present, the public health systems, in the country, they are using our device. The PSC under the State Department of Health, they buy the device and implement in the public community health centers across the country. And especially in Maharashtra, we have sold a lot of devices. And apart from that, even ENT hospitals are buying our device, medical colleges are buying our device, cancer hospitals are buying our device for screening purposes, because they have the student population with them. They use the device in their community programs and outreach programs across in rural pockets also. In one dental college, they have installed the device in an air-conditioned bus, and they take the bus to the rural areas for screening purposes. Basically, what we need is a space of where you can set a dark room-like condition to set the things rolling.
Yeah, I was impressed by the evolution of the device from 2005 all the way up till now.
Yeah.
Do you see now as the end point, or do you see a further evolution of it?
There will be further evolution for the product also. We are working on identifying much more, a different kind of technology that can be integrated with it, like use of AI for automation of the ROI, region of interest marking, and all. We are working on that and updating the software so that the screening can be much more easily done in a shorter period of time. So we are working on that.
Well, congratulations on your product, and it's an amazing thing. And I wish you a great deal of luck with it. We'll talk more about it. And if people have some questions, they can lob them in the chat, and you can answer them while there's other speakers. Nina's been kind of doing some back and forth with other people, and you can too. We're going to take a quick break and take a little break and come back after 5 minutes. So let's come back at 10 minutes after the hour. 10 minutes after 10 o'clock where I'm sitting, and we'll regroup and we'll talk about drone technology and how that is really changing things in Northeast India. And we'll also have a conversation about the landscape of AI in portable ultrasound. And I hope you can stay with us, and we'll come back in like 4 minutes or so. Come back at 12, 10 after 10. Thank you.
Hello, Jeremy.
Hello, hi, Sumit.
Oh, yeah, good.
Why don't we get started then? It is 10 minutes after already, and
Yes.
I'm really interested to see your presentation. And I think everyone has been thinking about drone technology and wondering about its application in the global health field. And you've been out there doing it for a few years now, and it's really an exciting prospect, I know, for a lot of people in Northeast India. And Dr. Sumit Agarwal is not just a drone operator. He is someone who works as a scientist at the India Council of Medical Research and works in operational research on public health issues, sexually transmitted infections, HIV research, and other areas of interest are infectious disease and epidemiology. And I'm anxious to hear how you got involved in drone technology and what's being done with it there in Northeast India.
Yes, thank you, Jeremy. So I am pretty much excited about it. So let's begin with this. So it's actually named as a eye drone initially. So it has a backstory in that when everybody was facing COVID-19, so ICMR and India was also developing towards the vaccine. And before the development of vaccine, we were very much worried about how we would be able to deliver vaccine in Northeast area. Actually, Northeast India is a very difficult terrain, which has a hilly terrain and lots of difficulties in going there and delivering vaccine. So before the development of vaccine, we were very much worried about how we would be able to deliver vaccine there. So before the development of vaccine, we started developing, we started thinking. So we got an idea, let's use drone. And being a medical doctor, I have no idea, like apart from drones which we use in marriages for shooting. That is the only connection which I know about the drones. So that is how it started, and my boss said, "Okay, you have to do it." And you are public health expert. I don't know how you will do it, and you say yourself as an operational research person, so you do it. So then I started it, and so basically it is a spin-off from that scheme. So when we started, there was no idea where to start because being a medical doctor. And then we contacted many of the technical institutes, the defense person, the air forces, and many other people. And that time there was no drone rules also in the India where that they allow you to fly drone in the public fields. So lots of things was going on. The country was under the lockdown, so things was going on parallelly. So we got a connection with the Indian Institute of Technology, Kanpur. They have airfield, the airstrip there. So during the COVID time pandemic, we developed because whenever you are talking about public health interventions, first you have to do the feasibility study in the to understand whether it is possible or not. So we conceptualize it. Let's do it the in-field study under the controlled situations. So we conceptualized, we conducted this feasibility study with IIT Kanpur. And there we simulate actually how we store the vaccine. And that time there was no vaccine, so we used the dummy vaccines which was available with the Indian Serum Institutes, those who were developing vaccines. So after that, conducting this study, so these studies were conducting during the lockdown, and the results was very encouraging. Like temperature stability was there, physical integrity was there, and drones were actually able to carry the vaccines, maintaining temperature and everything. But there was few limitation also. All these things were the visual line of sight where you can see the drone and you fly the drone. And also everything was being done by the experts. And also it was everything was a high controlled thing. So we presented all these reports to the higher officials, ministry, and then we just wanted to have a easy escape from this. And we thought we will deliver vaccine in planes of the India, basically, which is a UP, MP, and these are bigger states. But they said, okay, we don't need it there. We need its most difficult terrain, which is in Northeast India. And you have to go there in Manipur and Nagaland, and you have to deliver. So that is how we started, and that's after that it was acronymed as a drone outreach in Northeast. So there was lots of exemption and support was given to us because there was no drone rules that time. So earlier there was only visual line of sights was permitted, but we got beyond the visual line of sights. There was some restriction about the altitude related and the timing related, and we have to every time get consulted with the air traffic control people. So this is the map of India, and you can see I have highlighting two states, Manipur and Nagaland. Both state you can see like more than 90% area is the hilly terrain. It's totally hilly terrain, and roads are really, really difficult to go there. So we started with the both state governments, and we took all the permission from the state government. And actually, ICMR was also not having any drones because we are totally a medical research organization. So we did procurement from the public sector on the drones. And when we talk about now here, the health perspective comes when we talk about the feasibility study and practicality of it. So we also conducted the study on the acceptability, adaptability, practicality, integration, and implementation. We are keep talking about the human centric approach because just putting a vaccine into the drone, transferring it to the other places just doesn't make it human centric. Once you understand what is the acceptability of the stakeholders, whether it is a beneficiaries or the healthcare worker, whether they are trainable or not, adaptation, practicality also is very important. Here you can see with alongside the practicality, this is a rooftop of a primary healthcare center where there was no space for the landing. But we did this landing, transferring the vaccine on their rooftop. So this was very like challenging also, and we have to see the practicality and then the integration with existing because you are talking a new technology. You cannot develop a parallel system because that will have a financial consequences in future. So you have to be integrated, and how and who will implement it. So all these factors were initiated, and we were given the most difficult task because in Manipur there is a island named as a Karang. So they asked us to deliver vaccine there. So Honorable Health Minister that time inaugurated the sortie, and we delivered the vaccine through the drones, probably first in Asia, and very few country has done this. So this was not just the demonstration. After that, we covered the both states, the various landscape, hill to valley, hill to hill, hill to land, valley to valley. So whatever permutation combinations were there, the most difficult terrain we covered in northeastern. There was lots of challenges which were there related to topographic data, transportation and travel, takeoff sites, language barrier, uh, apprehensions of the people because they have not seen drone flying carrying vaccine. They have seen drones in negative sense all unavailability of facilities, the insufficient manpower, and high time consuming. So these were the challenges for healthcare worker, which we were trying to sort it out with the drones. So here I highlighted one point, like if you can see the last in the row, there was in one place, district hospital, Mokokchung to Twinsang. So that is distance is just 90 kilometer, but terrain is so difficult, it takes 8 hours by the road. And by the drones, we were able to transport things by just 37 minutes. So you can see the impact of all these things. We were able to transport everything by 25 minutes. So you can see the impact of it. And the cost by road is $400 if you talk about the money part of it, direct and indirect cost. But the by drone, it was just $100. So these innovations were innovative, but also the cost effective also. The cost effective innovation studies are also going on. So in all, we conducted 80 sorties and we trained many of the more than 76 healthcare workers, and we connected many of the difficult district hospital, community health center, and tertiary healthcare center. So more than 900 kilometers flight was taken, more than 20,000 vaccines were delivered, and the population is very less. So these were the very important number for that terrain. So this thing was highlighted in one of the few innovation that happened in India during that time, and in that features Honorable Prime Minister and Bill Gates and many reputed people from the world. And this was released on History TV 18. This was, and what we did with help of all these things that leads to a guidance document, use of drones in healthcare and also the training modules. So ultimately, these documents were released, and these documents helped us in shaping our policies. These are the now standard document in India. So after that, we were happy, like we concluded it very successfully. But this was not end of it. We realized it is just a starting point, because then we realized there are 4 or 5 more priority areas where we need some quick solutions, like for transportation of blood, and we will see the further for helping out the elimination of TB, for transportation of the basically strengthening of the peripheral hospitals and the Himalayan regions in there in India. So they have -10, less than -10, and they are very at the very high altitude of 12,000 feet, 15,000 feet. So we also then taken up 4 more studies, and these were distributed to 4 part of the India. So we'll take up like quickly one by one. So first study we took after that, you can see like these are the AI, again the AI generated. We are talking about AI, so AI generated only. So this just show the landscape of Himalayan region where the temperature is -40 and altitude is more than 11,000 feet. And it is really difficult to transport the medical supplies, samples, and many things during these snowfall time. And it is very difficult. People cannot move and they are restricted with the things. So the government of India gave us challenge. Okay, you do it because this is a very difficult terrain for army people also, and you are the civilians. So we planned a feasibility study there, implementation of drone-based delivery in that high terrains, hard to reach terrain of cold mountain of that Himalayan region, identify the challenges, because if we are able to identify challenges, we would be able to scale it up in future and assess the acceptability definitely. And we kept it very short for 6 months, and then we did it definitely, and we delivered more than 1,000 medical supplies. 20 diagnostic samples were taken up. We connected many of the district hospital, secondary care hospital, and tertiary care hospital, and primary care hospitals. And lots of challenges actually we realized, and that we documented also. There are lots of, like, because these hilly terrains have a high, or so there is a disturbances of electromagnetic waves. Temperature is very low, below sub-zero temperature, so batteries doesn't perform optimally. What drone was giving us endurance of 50 minutes, they were flying for 5 minutes. So we did all these optimization. We also published a paper on that was published in BMJ. So ultimately, we learn a lot from these things, and in between, we were using AI. So I will explain it later. Second scenario, we were given a situation where we want to transport blood bags and blood products from the urban area to a rural area. In rural area, blood is very sensitive material. You cannot just keep it in simply. It needs some specific temperature and the conditions. So we wanted to check if we are transferring blood through a drone, whether it is changing the quality of blood uh, biochemically, bacteriologically, and other conditions. So we took multiple products of blood, and we conducted this feasibility study. And we found, like, whether you take it by drone and whether you take it by road. So the both results are comparable. We did intra and inter and intra comparison, we did it very systematically, and we realized there is no difference if you are using proper SOPs. We did it for PRBCs platelets. So there was lots of challenges that we have also documented, and definitely we are writing on paper. It is under the review, so that soon will out. So ultimately, if we are using SOPs, so definitely we can use the blood through the drones. So these are few. The third is very innovative things like, there is a high technology which we say is a frozen section analysis, which is only available as a tertiary care hospitals, and that needs expertise. But in India, secondary care hospital and primary care hospitals where surgeons are available but pathologists are not available. So whenever you are doing surgery, so you need that frozen section if you want to diagnose during the operations about the oncology, means whether patients are having cancer or not. So what we did it here, we did very innovative things with the drone. So we did the intraoperative transportation of the sample, pathological sample, from the secondary care hospital to tertiary care hospital. By that, secondary care hospital were able to use as a tertiary care hospital, and reports was communicated to the surgeon and patients during the surgery. So there was no need for transfer of patient to higher center or calling them the second time. That reduced the costs, and that increased the services available at secondary care hospital. So that we did it. So here I know there is a time paucity, so I'm just getting it quickly. So here we did almost 20 sample, and we got 5 sample by frozen sections. So that was not possible earlier. The fourth case last, we are using, as ma'am was also talking about the TB. So now there in India, lots of hilly and tribal areas are there where people have a very high attrition rate. If you transfer them to the higher center, they will not come back to you, or they will not go to the higher center. So we used a drone to transport these sample from the various PHCs and CSC level, which is primary and secondary care hospitals, to the tertiary care hospital, where we can get diagnosis through the sample and sputum sample examination. So this was the full program where we covered full entire district of the in one of the major state in India. And here we were able to transport lots of sample over the year, more than almost 1,500 samples, TB samples we were able to transport. And we also documented lots of challenges and the things. So basically what we are doing, it is trying to minimize the attrition, or it is trying to remote healthcare services delivery, or it is increasing the centralized supply, or reducing the time for action. So, uh, so there are also, when we are implementing all these, there was lots of challenges, technical, weather related, logistics, and administrative and socio-behavioral, because these we covered a large landscape of the India. So we started with the vaccines and medicines, and then we came up to the blood and then high altitude. Now we did the intraoperative and TB sputums. On 25th, we are doing the first transportation of cornea, and followed by the transplantation. That would be the probably first in the world. And we are also trying to transport renal kidneys through the drones, and that we are working, probably that will happen in 26. So all the studies was conducted looks similar, but every time there was a unique propositions were there. In all of the places we are using AI in terms of, like, when we are planning the routes, how the drone will fly, because many times there are no GPS or networks. So we are using AI by creating KML files. Also, we are maintaining, like, these all things needs the cold chain maintenance. So AI is helping us with a smart sensor if there is an increase in temperature. Also, when we are using TB samples, so they are helping us in the diagnostics and turnaround time optimization. We can do with a AI-based real-time tracking of all these things. So there are lots of, and also one important thing is the QR-based landing of the drones when there is a very difficult terrain, which I show in the northeastern area. So till now we have published more than 8 research publications that includes BMJ, JMIR, and many other. Total funding we have taken, just it is a $0.35 million to operational guideline has been come, and it's influenced multiple policies. Now we are also planning AI-based bat behavior, which is important for Nipah and Ebola virus, many other things. and also the mosquito identification to see the vector control, to strengthen the vector control program. So till now we have published, so these are the few paper which we have published, and this is our team, largely supported by young people. And just thank you. I was very quick. I know the time is short. So thank you, Jeremy. I hope I was able to convey my thoughts and work to you clearly, and the to audience as well. Over to you.
That was great. That was really miraculous in a lot of ways. I'm kind of overwhelmed, and I wanted to ask a couple of quick questions. Where was AI the most helpful to you? You kind of ticked through them so fast, and I mean, it seemed like me like, oh, the geospatial stuff. That's got to be really helpful to figure out your flight patterns and things like that. Where was it most helpful to you?
Actually, we are using AI in many way, but when we talk about northeastern India, where is the network is very poor, so we use QR code and that AI tools. When we generate KML file, even though network is not there, that AI tools will help us to locate the exact point where the drone has to land. So while tracking the route and also in the landing, when we are landing specific, because drones are very sensitive and you cannot fall it on some people or some like family or some house. So we have to land it properly. So that is how like drones is being used with the like clubbing with the AI, and we are using it. But now the most important factor, we are using it to identification of bat. You know, bat is related to transmission of Nipah virus. So we are trying to do Nipah virus like bat behavior that will connect us to the epidemiology of Nipah virus. So there also we are trying to use AI. So there are many places. All I feel is important.
All right. And is there, have you compared yourself to other places where they're using drone technology to deliver medical devices? I was reading that Ghana does a lot of drone delivery. How did you gain inspiration from other places? Is there other spots that are similar?
Yes. Actually, we started, Ghana is using for blood bag distribution, and they are doing it since 4, 5 years, many years, 6, 7 years. But we started with delivery of vaccine and medicines. And now we are increasing to the cornea and the organs, because you know in the city it is really difficult to transport organs when like we are heavily populated, you know, in India, Delhi and Mumbai. So you don't have space to run on the road. So you have to fly drone. And lots of places where we are using drones, definitely for the mosquitoes identification in vector, because the India has a large the forest area. So we are also trying to get in with the drones and the AI.
Uh, is your How do people look at your team now? I mean, I imagine the demand for this, just judging from the scope of where you're working now, is you've got to be in high demand for some kind of.
Yes.
How do you
Definitely.
gauge
If you
all
see
that?
my team, if you see my team, I'm a medical doctor, but we have anthropologists with us, we have biotechnologists with us, and we have engineers with us, and we have pilots and drone experts with us. Because it is not just about the technology. So we are always talking about human-centric approach. So we are involved with psychologists, anthropologists, and many other people, those who are involved in that. And definitely on like 25th, we are having the first cornea transportation by cornea transplantation. That would be first in world. So yes, that it keeps us on toes. So we are having high challenges every time.
Do you have another example of, you gave the example of, an 8-hour trip being a half hour with the drone. Are there other examples of that? Or is that kind of not untypical, or is that an extreme?
Yes, so I told you one example in Karnataka is a state in in India. And in India, there is a health system where you have primary healthcare, secondary healthcare, and tertiary healthcare. Usually, you get the most advancement technologies at the tertiary healthcare system, but not the secondary level. So what we did during the operation, so like at the secondary level, there are surgeons which are well equipped to conducting any kind of surgeries, but we don't have that equipment at the secondary level. So what happens whenever patient is coming and we are suspecting it is as a cancer patient. So either we will ask him to come again or we will refer him to the higher center. So with the use of drone, what we did, we took up the operations. During the operations, you can believe during the operation, we transported that sample to the higher center and everything was going live. And the pathologist received the sample. He examined the sample in within 30 minutes. He communicated reports to the surgeon, and surgeon was able to take decision whether it is oncogenic means cancerous or non-cancerous. And by that, we conducted 20 surgeries, and 5 out of that was cancerous. And we were able to cut down the cost of the surgeries, cut down the time of travel, many other things. So this we felt is very innovative. By that, because population is less at the secondary care hospital, you cannot establish the big hospitals because we have the cost and resource constraint setting. So then these are the technology which can make your secondary care hospitals as comparable to tertiary care hospitals. So there would be a lots of example, but I guess this
One
was clear.
last thing. How has this transformed your thinking about technology and how AI and drone technology can really change the medical global health field? I mean, you must be an entirely different person than you were when you started this before the pandemic.
Yes. So I feel like both things, drones as well as AI, they are in very initial stage. And with these initial nuances and advancement, we are able to do lot much, like a lot we are able to do. But once we will have more advancement in AI related to the image processing, and drone will become more of weather resistant and the more controllable. So I think that will change the scenario related to vector-borne disease, transportation of the so definitely these I feel are the top 5 technologies which are coming maybe in next 20 years. And once we will have that, will make equipped like lower class, like lower levels of healthcare, primary and secondary, more equipped, which would be equitable to the like tertiary care hospitals and more. So I think we would be able to resolve more of the problem which we are facing now.
Sumit Agarwal, thanks very much. That was a really interesting presentation, and congratulations on all your work. It sounds like it's making a huge difference for many people. Thank you very much.
Thank you. Thank you, sir. Bye. Good day.
Now we're going to come back to the States, and we're going to talk with Dr. Joshua Gutman. He's an associate professor of emergency medicine at Emory University, and he's founder and CEO of Peachtree POCUS, and that's a leader in point-of-care ultrasound. And they're integrating artificial intelligence and ultrasound and revolutionizing how clinicians use point-of-care technology. And it's great to meet you, Dr. Joshua Gutman, and anxious to hear your presentation.
Thank you so much for that introduction. I'm going to be sharing my slides in a moment. All right. So set this all up here. Today we're going to explore
Captain Kirk in there. That's great.
Yeah, today we're going to explore an exciting frontier in frugal medical innovation, how artificial intelligence is integrated into in point-of-care ultrasound to really go boldly where no imaging has gone before. My name again is Joshua Gutman. I'm an associate professor of emergency medicine at Emory University, and this may be the first time some of you are hearing about point-of-care ultrasound. So we'll start with a little bit of introduction on that, and then see how AI integrates to really bring imaging to the low resource setting. There's some of my disclosures. All right, so what many of you typically think of ultrasound, or in more traditional ultrasound, you have the doctor, you have the patient, and then when the doctor says, okay, this patient needs an ultrasound to diagnose a clinical condition, you're going to send them over to the technician in a different area. The technician then performs the ultrasound, acquires the ultrasound images, which then get sent over to the radiologist, who has no real direct contact with the patient, who then interprets the ultrasound, which then gets sent over back to the clinician or the doctor treating the patient, and the doctor integrates that reading into the clinical care and decides what to do next for the patient. And so point-of-care ultrasound is different. So it takes the physician, moves them into the role of the technician who's also acquiring the ultrasound, but then also takes that role of the radiologist per se, and also becomes the person interpreting it. And that's really what point-of-care ultrasound is taking the ultrasound technology, moving it into the treating physician's hands, bringing it to the bedside, and then that physician can then incorporate what they're seeing right in front of the patient into the clinical care. And so the conditions that are diagnosed with point-of-care ultrasound is very, very broad. And so it has large applicability. So bringing this into the low resource setting certainly is very helpful for patients in diagnosing a lot of both emergent and urgent and screening medical conditions. Ultrasound is also great with procedural guidance. Instead of using landmark techniques, you can actually use point-of-care ultrasound to see let's say the vessel that you're going to cannulate. If you have central venous access, it's now standard of care in the United States and in much of the world to use ultrasound to cannulate veins. So it can be used to actually see where you're going, making sure that it's more accurate, but also making sure that it's safer and that a needle that you're putting into the body is not hitting anything that it shouldn't be hitting. So let's talk about a little bit of the evolution of point-of-care ultrasound machines. Here on the left, this is not a point-of-care ultrasound machine. This is what many of you probably know if you ever had an ultrasound. You have this big fancy machine that the technician has that's very large. It's not portable, it's bulky, and it has many, many buttons and is difficult to use and takes definitely specialized training. In the late 90s or early 2000s came in this type of machine. This is a cart-based or laptop-based machine. It's basically this laptop stuck onto a cart. As you can see, it's smaller and very portable. It also has way less buttons, so it's much, much simpler to use. In the later 2000s to 2010s, we came into this type of machine. So this is also a point-of-care ultrasound machine, but it's gotten more sophisticated. The image quality is much better. The resolution is better. It's touchscreen, still on wheels, still portable, and still pretty compact, and still relatively simple and easier for the novice user to use, someone who's not an ultrasound technician and using those machines. And into the late 2010s and 2020s and into today, we've actually gotten even smaller. So we have machines that can plug into the phone. Now, this is a butterfly machine, but there are several on the market that can plug into a phone or iPad for really, really the ultimate portability. And how this makes a difference, especially in low resource settings, is the cost. These bigger machines are very expensive, $200,000 plus, and they come with superior level quality, but they're unaffordable in the low resource setting. And even these other machines that are more point-of-care ultrasound related, they're still quite expensive in the tens of thousands of dollars, really around $40 to $50 or more $1,000. So they're still, when you're talking about frugality in lower resource settings, this is out of reach for a lot of places. But then you get into those phone-based machines, the ones that use your phone or an iPad as the screen, when those ultrasounds just plug into there, whether wired or wireless, and they get into a price point that's actually quite affordable. This is the newer butterfly ultrasound called the IQ3. So it's about $3,900, but even their previous model that they're still selling and is still excellent, the IQ Plus, is only $2,700. Here's another one called Echo. It's only $2,950. So this is something that can be purchased by a global health physician. If you're going yourself, it's in that price point of individual purchase. If you wanted to donate machines, or you can get a few relatively small donors to be able to buy one or more of these, or it can be purchased by the clinic themselves at a reasonable price point. And now you're taking the imaging that was previously very, very inaccessible and putting it to a price point where that imaging can be delivered at the bedside, even with very low resource finances. So how do we get this great ultrasound technology into the hands of our low resource physician so they can be able to do the imaging? So when talking about how to get it into their hands, we have to understand that point-of-care ultrasound involves actually multiple skills. And kind of as I referenced before, you're the ultrasound tech, the radiologist, and the treating physician at the same time. So you have image acquisition, you have image interpretation, but you also have clinical integration. And so it takes all those skills that come together, and is where point-of-care ultrasound is so special and unique from traditional ultrasound. And so how do people normally learn? Normally you go to a course, either you have instructors that will go to a group that will deliver a course and they'll scan on models and learn kind of in real time, or you'll have learners that will go to the instructors and you will teach kind of like a normal course. And then from there, after getting that course, they will then go scan on real patients in real time and get feedback as their images get sent for quality assurance to experts for both feedback and imaging quality education. They get better at it. So that's how normally ultrasound is done. That's how it's done in the United States and in other Western countries, and how that education happens. But there really is limitations when we're talking about global health and low resource settings to these type of live courses. Tons of funding. It takes quite a bit of money, not just for the equipment, but to get the instructors over to the physicians, or the other way around. You have to have educators that have this expertise, that are willing to travel to those low resource settings. You certainly have equipment limitations, and you sometimes have political turmoil in that destination country, where in places where it might be needed the most, that they really don't have access, might be dangerous to travel to. So there's a lot of limitations from this standpoint. On top of that, the ongoing education and the quality assurance that I discussed has its own limitations. There is often no local expertise, which is why these courses are happening in the first place. There's no local quality assurance. And then what ends up happening is, even if you get this course together and physicians or clinicians learn in that setting, then they go to their patients and then they start doing it. And then maybe they don't have confidence, or they're not sure, and they get no feedback as to how they're doing and how they could adjust their images and improve them. So when they lack confidence, people don't do it. And so in the US, I may give a course year after year and see the same people coming back because they don't use it. And if you don't use it, you lose it. And in that you don't do it, it leads to skill degradation, just like anything else, especially when you learn something for the first time. So if you don't have those pieces in play, then it gets hard to learn. Okay, so that's really where AI comes in. And AI, what it can do is it helps in both the image acquisition and image interpretation, to help those low resource clinicians and physicians get more confident and make diagnoses. So let's talk about image acquisition. And what I'm going to do is show a number of videos, either that I've made myself as far as reviews of the specific products, or by the company themselves, and show you how they're using AI and integrating it into both image acquisition and image interpretation. Since point-of-care ultrasound may be new to most of you, or just ultrasound in general, I'm going to be using some terms that may not make 100% sense, and it's beyond the scope of this talk to explain every single ultrasound term and kind of give an ultrasound course within here. So just don't worry about the terms if you don't understand them. Just try to get a sense of what the AI can do. So as far as image acquisition, it can help anatomic labeling, so actually label the structures that one is seeing on the screen. It can help with real-time probe manipulation. So it can actually tell the physician how to move their hands in order to get good images. And if you get a good image, the AI will know and it'll auto-save. And so I hope these videos, you can hear them, and you'll see what they can do. Here is the Echonos Cosmos. It's a portable ultrasound machine that plugs into a phone or tablet. And so watch how it does some AI labeling and image acquisition assistance using how it uses AI to help with image acquisition. This is for the heart. All right. So you can see how that uses AI to both label and tell the physician what to do and auto capture. Let's look at the next one. This is a GE V-scan with Caption AI. And so Caption AI is a company that GE bought to add to their V-scans, and it does something similar with their auto capture. Awesome. So very similar to the Echo Nose and does that for you. And these are already on the machines. These are not something you have to purchase separately. If you purchase one of these products, it will come already on it. Here's another cool one that takes, again, for the heart in a different way. So this is a product called Heart Focus by a startup called Desky, and they basically gamify it. And so what you'll see, what they're going to describe is it has this white cross on the screen, and then when you put the ultrasound probe on the patient, there will be a purple cross that will come up. So then the AI knows exactly where your probe is and where it needs to go. So you have to cross your cross onto the screen's cross. You'll see what I mean in a second. So even if the physician wasn't good at following word instructions, or maybe English wasn't their first language, they can actually acquire an image in this way and then either interpret it themselves or send it to a cardiologist, for example, or another expert in order to interpret. Moving away from the heart for a second, we're going back to the Echonos Cosmos device. This is an image of a kidney and liver when doing what's called a fast exam, which is a scan done during trauma to look for blood in the peritoneum. So it also can AI label this way. All right. So here is a company called ThinkSono, and they've created a product to help a physician do a DVT ultrasound or deep vein thrombosis. And so how this is diagnosing deep vein thrombosis basically has you finding the the veins and arteries in a leg and then compressing them in order to see that they compress. If they fully compress, then you don't have a DVT. And so this product walks the physician through the process of getting that image, highlights the veins and arteries, and helps them know that they have a great compression in order to either diagnose DVT or rule out DVT themselves, or send it on to an expert. Watch to see how they do it. So the AI both allows to know if they've done appropriate compression and helps highlight those vessels, and so the physician knows what they're looking at. So that was image acquisition and some of how AI really helps the physician actually get a great image. But now let's move on to image interpretation and actually having an AI do a read of the ultrasound in order to make a diagnosis or provide some clinical numbers or to provide some clinical numbers or to really help the physician along and not only acquire the image, but then read it. A lot of this is done with cardiac, but lung, bladder volume, and OB are other examples I'm going to show you of some ways that it could be done. This is a product called the Echo Iris. And what it can do, and other companies have done this as well, but here's an example of actually calculate an ejection fraction of the heart. And so this is typically actually not easy to do, and technicians are trained in order to calculate an exact ejection fraction. But now with point of care ultrasound, AI can actually do that for you. Watch to see how this is done. So this is great if a clinic wants to screen for congestive heart failure or follow patients with congestive heart failure without needing to send them for an expert performed echo in red. This can be done right at the bedside and really brings it into the novice's hands and ability to calculate an ejection fraction, which is so important in cardiac care. This is a Mindray device that it has something called Smart IVC. IVC stands for inferior vena cava, and it is we look at this vessel to know if we should give as physicians, if we should be giving patients more IV fluids if they're in shock, or if they will tolerate more IV fluids. We calculate something called a compressibility index, which is basically the percent collapsibility of the IVC. And so what the Smart IVC can do in this short video, there's going to be no sound in this video, so don't worry if you don't hear anything. It finds the IVC in and of itself and will calculate a compressibility index using AI. So it found the IVC, and now it's calculating the compressibility index, which is put up here in a number, which can be a little bit dynamic, and then it provides a collapsibility index over there that then the physician can then use to know if they should be giving more IV fluids or if the patient will be fluid tolerant. This is really cool. This is a company called ASAP, AISAP, and they've actually developed an AI workflow to actually create an almost entire echo report. So just doing a point of care ultrasound on a patient at the bedside, it actually uses AI to read it's a good 10 factors that it'll be able to read and calculate really within 30 seconds of it being done. Here's part of their video showing how it's done after the images are complete. So as you can see, it actually it just uses AI to just calculate all these different factors. And then, I mean, it's a little blurry here, but you can see there's some green and some red and some yellow. And so that is actually helps with the diagnosis. And so even if a physician is working in a low resource setting and they're not sure if the figure they're getting there, the number is normal or not normal, green, they'll know, okay, green is normal, red is very abnormal, yellow is in between. And they can also send a report like this to a cardiologist, for example, remotely, and get assistance into how they should be treating their patients and get that remote access. And so this really brings an almost full echo really up to the bedside. So this is really, I think, some of the future of AI in making these full diagnoses of ultrasound and creating essentially a full echo. Onto the lungs. This is the Butterfly IQ3, which has a B-line calculator. B-lines are lines that are found on lung ultrasound, which if there are many of them can indicate fluid in the lung or pulmonary edema. And so normally a physician would have to sit there and count the number or count the minimum number, usually 3 or more is abnormal. But this AI can actually count it for you. So the physician doesn't have to count themselves, or if they're not sure, it'll actually give you a number. Let's see how this works. And so that actually comes with the machine in itself. So it doesn't even need any separate software. So that's right there for any user to use. This is a company called Deep Breathe. No videos from them, but they've actually taken lung ultrasound to the next level. And so they've been able to diagnose pleural effusions and quantify pleural effusions as small, moderate, or large using AI. And they've also used AI to detect lung sliding. Lung sliding is what's used to rule out a pneumothorax or a collapsed lung in patients. And so if with the B lines and these pleural effusion and lung sliding calculators, you basically can have AI that can perform an entire lung ultrasound for a patient. So you really this AI is really moving along nicely. This is a Butterfly IQ3 that is doing a bladder volume. And so if someone doesn't have a bladder scanner or is not sure how to calculate a manual volume on ultrasound to know if someone is in urinary retention or not, you can use the bladder volume calculator that on the Butterfly IQ3 that uses AI to do that. Here's how it happens. So this actually can just with AI finds the bladder and gives you a bladder volume. So it's really cool. Lastly, I'm going to talk about FAMLY, which stands for Fetal Age Machine Learning Initiatives. And this is a study that's actually it's ongoing. They've developed the AI, but it's an ongoing study between UNC's Chapel Hill and the University of Zambia. And what they do is use ultrasound sweeps over a third trimester pregnancy. And so the physician would basically just do ultrasound sweeps over the pregnant uterus, and to be able to tell both the gestational age and fetal presentation, or which way the fetus is pointing, which is really, really important for maternal health, to be able to predict a difficult delivery or a more routine delivery, and to know when they're going to be delivered, especially without expert sonographers available. And so this is a study where they did the AI estimation of gestational age, and what they found is that the AI was really correlated well. It was a negative 0.6 days compared to experts, so it's really considered non-inferior. So really, they got within a day of gestational age as compared to an expert-performed obstetric ultrasound. And as far as fetal presentation, is if the head is down or the head is up, it had a very, very high sensitivity and specificity compared to expert review. So it was really excellent. The AI was really excellent in determining fetal presentation and gestational age. Lastly, just from a procedural standpoint, just going to show some needle guidance. And so this is both the Butterfly IQ Plus and IQ3 has this product called NeedleViz. And when sticking a needle into a patient, here it's into a phantom model, it can highlight the needle in blue. And so it helps a novice user be able to find their needle when it sometimes otherwise might be difficult. Here's how they do it. So normally it does not look that obvious at all. And so, conclusion, the ultrasound machines are getting more affordable, so they're becoming more accessible in lower resource settings. And then when adding the AI on top of it, you really can add additional expertise, both to guide expert imaging for remote review or for review by the physician themselves, and interpret imaging in and of itself. And so when we think about frugality in global healthcare and really trying to cut costs while increasing quality, using ultrasound and adding the AI on top of it is really is both the present, as you can see, but is also the future at getting really excellent tertiary level care to the low resource settings. And really, we're at the beginning of making this the ultrasound machine really the tricorder that hopefully it will be one day. Thank you very much, and I'm happy to take questions.
That's really impressive. And I've got a million, but I guess I would just go with how widespread is this right now? Because there seem to be so many products and such fulsome development. Is how many people have taken this route?
Yeah, so the on the machines themselves, so the Butterfly, the Equinox, the GE, they're pretty widespread and they're everywhere, and those are already on machines that are being sold. Some of the other products, the Heart Focus and the ASAP, and those are just getting started. And these are startups that are relatively new, but they've developed these great products. They're FDA approved, and so they are still making their way into the global health and into medicine and of themselves.
And how much of a difference does it make in the diagnosis accuracy? You know, you were talking about, you know, the ability of it to diagnose correctly and label correctly, and is it that much? Is it better than the system that we have now? Would you say, hey, I know you've got that device, but I want a radiologist to look at this. I don't want how do you gauge that kind of accuracy if you were a patient, if you were somebody doing this?
Yeah, well, I think when you think of the lower resource settings, they may not have access to a radiologist, and so or they might have an access to radiologists remotely, but don't have anyone to actually take the image themselves. And so that's where the image acquisition comes into play. And so even if someone said, "Hey, I have a radiologist who will read it, somewhere else," but they actually need the right images. If they don't have a good image, they can't interpret it. Then the AI can actually get those good images, and they can be sent over via the internet to a radiologist to read. Now, as far as accuracy, they are very accurate. Now, you would say, would I want a radiologist or a cardiologist? Yes, of course, but that's not always the case. And right now in these low resource settings, they don't have anyone, and so this is 100% better than having none of this imaging available. They're accurate. I mean, I'll talk about the echo in and of itself. Like those numbers are accurate. They won't come up 100% of the time, but they have been studied. There's been several thousand patient studies that have gone into that product. There are some elements that I think a cardiologist would be a little bit better at, but as compared to no imaging, no access to experts, this really changes the dynamic.
All right, Nina lobbed a question in and asked, can you talk about the informed consent process on use of data and how and where this has been trialed in LMICs?
So as far as these are all FDA, all the things that are here, except for DESCI, which should have FDA approval this month. Now it's only for education, so they're all FDA approved. So there's not really, I don't think, much for informed consent. I'm not sure what an LMIC is. If you can.
Me neither. Let's fold everybody in, and we'll have a little bit of a group chat here, and kind of conclude the day. I do want to mention that there's going to be an evaluation form that pops up, and if you could just fill it out, it only takes a minute or two, and there's just a few questions, but it'll help us with next year's program. If Nina's with us and wants to pop in and ask a question of Joshua about what you were talking about, informed consent, pile right in.
Yeah, I'm not sure about I don't know about the informed consent. A lot of the I guess the butterfly, the image devices themselves are being used already globally. I don't know. I can't say I know really about the informed consent. The other products, those are just on the forefront. So I don't think they've been really used much in the global health setting yet. But the point is that this is the beginning. They're early on, and I think they have the potential to be used in these areas. They're already being used. Like the ASAP, for example, is already being used in the United States when it may take a few days or so in the hospital to get an echo done. These products are being used. ASAP is being used to decrease lengths of stay, and saying, okay, if the AI says that this patient has a normal echo, then that indeed is going to be a normal echo. The patient can get discharged to get a follow-up with a cardiologist if needed at some point.
Do any of the panelists have questions for each other about their presentations or what they've seen today? I want to kind of give everybody an opening, especially those of you in India. Thanks for staying up with us. Sumit, did you get anything out of the presentations here?
No, really, Gatman is doing a great job, and it would be very useful for a country like India. So, like, definitely where the facilities are not available, that is what I was talking at the secondary and primary level, where you don't have the big facilities, but definitely these will help out.
Subhash, do you have any thoughts about what you're seeing?
Yeah, I heard Sumit's presentation. The way the drone is being used is amazing. It can not only lift the patients, the medicines, but the patients also can be lifted to the hospitals also, avoiding the traffic jam, especially in the Indian context. The injury patient, head injury or somebody like that, if you can lift on a drone to the hospital, that will be amazing to save the lives.
Maybe in the future, definitely. It is the start of the drones and the AI.
Yeah.
Nina, do you have some thoughts about the presentations?
Yeah, thank you. Thank you so much. And thank you also, Sumit, for sharing your paper. I'm familiar with your work, and it was great to see the presentation. And I suppose to both Subesh and Joshua, my question around is around the sort of continuous data use. So we take these photographs, and it's continuous data use that feed the algorithms to improve the algorithms. And that's where I'm interested in the patient consent form. So often we go to the doctor and we get an X-ray, and we don't expect that X-ray to be loaded up to a data set, which is then proprietary or then used to sort of for further research. And that goes back to sort of my Henrietta Lacks point a little bit. Like the data is feeding into something. Did I consent to that? And then the second question is a little bit around the user informed. So I'm curious for Subesh. I mean, what generated this need for this design, and was it people? And for Joshua, you talked about global health problems and training and all of this, and how this technology is being used. And I know that you're not designing a lot of it, but for the people that are designing it, it sounds like they want to use it in low and middle income countries, but it doesn't sound like a lot of the clinical data or the trials. It is FDA approved, but how are they actually engaging with low and middle income countries, providers and patients in the sort of testing of these things? And I think that's what a lot of my presentation was trying to get to. Thank you.
So, no, in the case of data sharing, there are hospitals which refuse to share the data with us. When we have a cloud-based algorithm, we ask the users to push the data into the cloud so that we can have a better accuracy for feedback. That often doesn't happen. So when we ask them to install the software, we give them the option whether you want to share the data or not. Accordingly, the data sharing happens. In such cases, the data base becomes much more robust, and the feedback to the user becomes improved. And when we develop the device, the second question regarding the development of the device, when we developed the device, we made it such that the device is accessible to the larger population in the rural areas where there is not even electricity. So that's why we drive the device using the power derived from the computer, basically. If the computer is charged, then the device can be used in places even without any access to basic electricity, or even internet connection is not mandated, because when you get to the area where there's internet connection, the data sharing happens actually, not necessarily in the field.
Wish I was really asking about the people themselves. You showed a couple of pictures of patients, the people who are giving the data to the system, not the hospitals. That's the part of the informed consent I was curious about. Not the hospitals, but the actual people.
When we do the trials, we do the trials, we get the informed consent form signed by the patient, and that includes the data which we collect from the patient that can be used for our algorithm or whatever it is that is included in that, basically.
Is the form kind of readable, or is it one of those Netflix forms?
And the ongoing use as well. I mean, that's kind of the interesting part of AI, is that you get the trial, you get the device approved, and then people continue to feed their data into the system, but they're not being asked. They're not being asked each time. They sign that Netflix form once, maybe for their clinical trial, but they're not being asked each time if they consent to have their data uploaded to a proprietary system, which is being sold to others. That's the part that I'm really, and it's all new, but I'm just curious how you're handling that with your own work.
Well, as far as we are concerned,
yes.
Sorry.
Yes, please continue.
And as far as we are concerned, we don't take any images actually. We take only the data which derived from the images into the algorithm, not the patient photographs or anything like that.
So I have just one query from Joshua. Like currently they are developing a AI tool which are being trained on their data set of their country and probably the localite area. But when they will come to the other part, LMNCIs or the lower income countries, then definitely they will be needing the data training on their data set. So like it is not directly you can take your devices to these countries without the validation, without the uh, local contextual setting, because you will be needing lot of local data which will be needed. Maybe you have model, but you will be needing the local images and local context like how they do it. So probably when you are shifting to the local or some other country, you will be needing their local data and validation separately, apart from what you are doing at your place.
Sure. I think the ethical question of uploading data is a good one. I could tell you even in the US, everything is de-identified, so those are all uploaded de-identified, and at least in the US is considered that's considered okay, and that data can be uploaded to a system, and it's the same in some other countries. I think in Europe it's a little bit more difficult, maybe because of ethical reasons. I don't know. Um, but yeah, that's a good question. And yeah, I know some of the companies, Butterfly, for example, and some of the other ones just work with global health. I know they are in other countries and they're providing their equipment into other countries to low resource settings. But I don't know from a regulatory standpoint, how that's working for them. I just know they're doing it.
Is that kind of a Wild West situation then? Is that I
think that's
Again,
what we
it's
found in our Lancet review. That's the term that we used among our own researchers. Lots of tools, people putting them out there for LMICs, and as Sumit said, not having used any data from local populations in those tools, and not having tested them against the standard of care. Is it better to lift up somebody's tongue, or not having tested them in terms of efficiency against the standard of care.
right. I think
So yeah, Wild West.
right, but people, if they don't have access, this is certainly better than nothing. And I think I don't know that you always need local, like for some things you need local data. But an ejection fraction for a heart, you don't a heart to heart. Like I don't see that's going to be different whether have US data or European data or elsewhere. I think if it's conditions that are specific to that population, then for sure. But I think it is applicable to a certain extent. And again, these are the use of things like this are going on in first world countries. And so it's not so much of a stretch to say it's not really, I don't think, too cowboy to say bring them over to third world where they don't have access to anybody.
Particularly, I can talk about my country. Definitely, when you are coming to India, then people will definitely ask regulatory people, have you validated it in the Indian context? So maybe like because the anatomy and the other local habits are different, maybe we don't know like what would be the effect on the accuracy. Maybe it is right, maybe it is some less or maybe more. We don't know. So definitely they will ask you to validate in Indian context. Only then will be allowed to use in India at large.
Right. I can tell you point of care ultrasound is being used in India. I have many colleagues who've gone over to India to teach locally. So um, at least there it's being used to a degree. I don't know to what extent.
For
This is
teaching
truly
purposes is different, but for the diagnostic purposes, it become a little more.
No,
Yes.
Yeah,
this is true in every country, actually. We are planning to enter Japanese market, so we have to do clinical studies in Japan to validate the device on the local population, then introduce it into that. Then only we get the regulatory approval from that country to use the device there. This is the problem. When we have to enter a different market with different kind of population, we have to do the trials there to validate it
right.
there.
From the AI, this is very early. So, I'm looking at it as a potential in these countries rather than what's existing.
I wonder if I could pull back for a second and just ask if there's something that you're really excited about that we haven't talked about today, an AI application that you know about that is out there and that you think has a lot of potential. Where is the field going when you think about it creatively, maybe outside the area of your expertise?
I think we see a lot of potential. Thanks for that question, Jerome. And what we talked about is the democratization of research, is that some researchers in limited settings just don't have access to the backup that they need. And so this idea that you can have ChatGPT or Claude help you generate code is kind of game changing, just in terms of how researchers with limited time and limited resource spend their time. So we see some of those tools of accelerating just helping people do research more efficiently is game changing for us, for really researchers everywhere. Over.
Definitely, I can say like with the coming up, the AI will change the scenario exponentially, not the linear. So what we will see in 10 years, that may happen in 2 years. So definitely it's going to change a lot, especially in diagnostics. It is going to be useful.
Subhash, do you have any thoughts about that?
Yeah. As Sumit said, diagnosis could be the major gainer for implementation of AI in various kinds of fields, like medical as well as in other, even disease diagnosis for plants and other things which are diseases of crop failure, crop damage due to nutrient deficiency and all. We can use AI for large farms and all, where the benefit could be enormous on the yield and things like that. Yeah. There's great improvement in all these fields.
Joshua?
Yeah, I think I've talked about all the ultrasound stuff that I think are exciting, but from a research standpoint, being able to have a biostatistician available on, with ChatGPT or whatever other AI, but also it's a product that I know of that's coming, that has been developed, that will has the ability to change formatting of manuscripts if it's going to be submitted to other journals, which is a pain for anyone who's submitted to one journal, has gotten rejected and has to submit it to another journal. There's just like a ton of time. So, and it could just do it for you if you say you want to submit it to this other journal. So it's something that's not ultrasound. It's exciting to me.
All right. And so we're expecting the speed and pace of AI generated help to accelerate, possibly very rapidly. It's already accelerating very rapidly. I don't know how to kind of quantify it, but it sounds like exponentially. That's what we should look for.
I think there's some really exciting things as well on optimization in as the healthcare workforce gets cut down. There have been some really interesting work actually in India, lots of interesting work in India on optimizing health worker visiting schedules based on using telephone data to see when people are home. That's a very exciting innovation in a resource limited setting, as useful here in New York City as it is in Delhi. And as well in sort of early identification forms for hypertension, or to allow, I mean, there's a lot of potential for reduction of maternal mortality by helping with referrals, by early identification of issues with pregnant women, with some of the wearables, et cetera. So there's a ton of really exciting stuff out there.
Well, it's been a huge eye-opener for me, and I'm sure many others on the call, about what's going on with AI and technology today. And thanks very much, Nina Schwalbe, Sumit Agarwal, Subhash Narayan, and Joshua Gutman. Thank you very, very much for today's symposium, and we really appreciate all your expertise. It was really, really terrific.
Thank you. Thank you for giving this opportunity to come on.
And I want to thank everybody who put this together. It's a great collaboration that happens every year between the University of Illinois Chicago, Loyola University, Rush University, and the India Development Service. And the people who do it are Supriya Mehta from Rush, and Tracy Pitchman from Loyola, and Neela Vora from India Development Service, and Allison Lofthouse, who we heard from at the beginning, from the School of Public Health at UIC. And thanks also to Keith Partika, who connects the dots for us in the conference. He does a great job. And as does Mike Yen, who does all the technical wonders and puts us all together very seamlessly. And it's been a real pleasure. And I hope to do this again next year and enjoy more eye-opening experiences with frugal innovations in global health. Thanks, everybody. And don't forget to fill out the evaluation form. It just takes a minute or two. Here it is. Thanks very much. And we'll see you next year, everybody. Take care.
Thank you.